Hi, everybody. Thanks for joining us this evening. I am extremely honored and excited to have Jessica with us this evening to present on a topic she's an expert in, head and neck cancer. This presentation is titled Tackling Challenging Head and Neck Cancer Cases. And if you are joining this webinar and would like ASHA CEUs, we are offering zero point 0.1 ASHA CEUs or 1 PDH for tonight's presentation. We ask that you stay for the entire duration of the event and that you complete a brief survey within 7 days of the course conclusion. I will put the link for the survey in the chat. It will also be sent out via email from Zoom at the conclusion of the course. If you're on a phone and you can't access it, no worries. Like I said, it'll be sent out via email, or if you don't get it, just send us an email at tims-unib@tims.com. Finally, if you'd like a certificate of completion, just send us an email at tims-unib@tims.com. And again, all of this will be in the chat. And if you have questions throughout the presentation, feel free to pop them in the chat or the Q&A, and Jess will answer questions at the end of the presentation. So with that, I'm going to go ahead and hand it over to Jess.
Thank you, Brooke. It's an honor to always present for Tim's University. Thank you for that introduction. And this topic is near and dear to my heart. There's just not enough continuing education on this particular topic with the really, really severe swallowing impairments and challenging cases and so forth. So I'm sharing 4 tough case examples, real life ones, and what I did to help them. And also give you some insight onto the tough conversations that needed to be had, because those are really hard and they don't teach you how to say in school. So let me just make sure my slide works here. Okay, so these are my disclosures. I'm a full-time SLP at Mayo Clinic, and I'm an assistant professor. And also, I co-founded Esophageal Collab, which is a teaching company along with Dr. Stephanie Watts to look at the esophagus clearance in the upright position, a standardized protocol during your X-ray swallow study. I'm also a contractor for Teresa Richards Group's MedSLP Ed LLC, MedSLP Collective. Contractor for FDI. I'm an MDTP trainer internationally, and then I am receiving an honorarium for this presentation. And then, so the learning objectives, we are going to define the SLP care pathway for head and neck cancer patients. We're going to distinguish intervention appropriateness of rehabilitation versus management. And we're going to identify approaches to difficult and uncomfortable conversations regarding healthcare-related quality of life. Okay, so speech pathologists at Mayo Clinic, Arizona provide a clinical care pathway for our head and neck cancer patients. So even if you work at a facility where you are not inundated or routinely seeing head and neck cancer patients, this is something that you can adopt and plug these patients into. Okay, what is the standard of care? So we are getting baseline data on breathing, swallowing, speaking, mouth opening, and lymphatics. And then we're reassessing at intervals to guide us in how we manage that patient based on where they are along the way in their cancer journey. Okay. Patient education and counseling are critical at each of these points of contact. And what are these? We see patients pre-surgically. We see them after surgery. We see them again before radiation. We work with them proactively during radiation. We optimize them after radiation. We do a reassessment at 3 months post-radiation, and then yearly until 5 years post. Okay? So, in the interest of time, we're going to have to go a little fast because I want to make sure that I have enough time to answer all your questions, and I've got a ton of information. So if you've worked with head and neck cancer patients, then you're hopefully familiar with the digest measure of the pharyngeal phase of swallowing, which provides a grading of severity of both swallow safety and efficiency. So safety is based on the penetration aspiration scale, while efficiency is based on the percentage of bolus residue after the initial swallow. Digest is validated for both fluoroscopy and endoscopy, and it's an excellent way to track swallow function changes over time or from intervention, demonstrating improvement or deterioration of function. And I'll be showing you this graph and discussing the patient's digest grades as we go through the cases. The graph's going to look like this. And so if you see my pointer, You and I were all a 0, no toxicity. You can have a mild, which is a 1, moderate, which is a 2, severe, which is a 3, or profound life-threatening, which is a 4. In any of the safety grade, any of the efficiency grade, and overall, these two come together for an overall grade of severity. So here are 3 more outcome measures that I'll be referring to as we go through the cases. I'm sure you're fairly familiar with the E10. It's the patient's perception of swallowing difficulty. That matters, right? Where a score of 3 or greater is clinically significant, you should look at the swallow under X-ray. A functional oral intake scale captures the functional status of oral consumption, ranging from 1 to 7. And the SOL is specifically for total laryngectomy patients. It's like the EAT-10 for a total laryngectomy, and you add up the score out of 34 points. And so it's great to reassess over time. So what's our agenda? We're going to be going over 4 cases. I selected them on purpose to make sure they are, 1, showing post-surgical swallow impairment, post-surgical swallow impairment followed by radiation, post-surgical swallowing impairment in the setting of chronic impairment, and then late effects radiation swallow impairment. Let's jump into case 1. So this is a 75-year-old male who was diagnosed with a left palatine tonsillar mass that extended into the soft palate, and it had mass effect on the epiglottis, which is, pictured here. Tumor board recommended either surgery, then radiation, or just straight up definitive radiation, chemoradiation, and the patient elected the surgery route. He was then referred to the speech language pathology care pathway. So the patient was seen for a preoperative counseling by the speech pathologist, where we established baseline functions that I mentioned earlier. We discussed the surgical plan and the anticipated changes or not to chewing, swallow efficiency, swallow safety, speech, breathing, and mouth opening after resection. We discussed the plan for tracheostomy tube, role of the passing mirror valve, role of the nasogastric tube, possible need for a G tube, and the SLP role in optimizing his functions post-operatively, as well as the speech language pathologist role during radiation. So it's always a lot of information. The patient's generally very overwhelmed, right? But pre-surgical counseling has a huge role. It's important. It really eases frustrations and, helps to reduce in these post-op readmissions. He was really particularly overwhelmed because his spouse was very sick, and he just felt like he he just, he's now got this new cancer diagnosis. It's a really large cancer, and he didn't really know what to do, but he had to put his wife into assisted living, and he just was scared. So he did not participate in many things. One of them being a pre-operative baseline X-ray swallow study. But at the time of the pre-op appointment, he denied any swallowing difficulty or pain, and he was eating an unrestricted diet. He then underwent his surgery. He had a transoral surgical resection of the left pharynx with a radial forearm flap reconstruction and a neck dissection. An NG tube and a tracheostomy tube were placed. He was in the hospital for 2 weeks with recovery complicated by flap failure, so that required another surgery. And you can see a small dehiscence here in his palate. He was decannulated just prior to discharge. And while he attended his post-op follow-ups with the surgeon, he did not show to his post-op SLP appointments because the surgeon had told him that given the degree of resection and how poorly he was managing his secretions, that he would likely need a G tube, and he did not want to hear it. So that was a bummer. We missed him. And after 3 more weeks of having been, he lost 30 pounds. He then notified the team that he was not going to undergo radiation, post-op radiation, which was the absolute plan, right? That's what the options was just definitive chemoradiation or surgery, then post-op radiation, given the nature of his cancer. So the surgeon asked me to call the patient, and I did. And I explained that one, it was unsafe to keep the nasogastric tube in that long because it's a harbor of pathogens hanging right behind and above his airway, not good for his pulmonary health. Two, we can't rehabilitate his swallow with the nasogastric tube in place. And he needs a more stable route of nutrition and hydration that will help stabilize his weight so that he can be healthier and do well in his intervention journey. So he did understand and he did agree to have the G tube placed, which was great. That was a win. And then he gained weight. So that was also a win. So ultimately he was came to us for a evaluation. What is his new baseline? 3 months later after surgery, which is a long time. That's not the typical norm, but I explained his kind of barriers and personal issues, but he came. So at that point, he was a functional oral intake scale of 2. So he is G-tube dependent, but he had 2 cups of coffee each day and water. His Eat 10 score was a 35 out of 40, which is not, it's not shocking. Under fluoro, I'm going to play the videos here. And just understand I've recorded them fast forwarding because it was so slow that this would just eat up a lot of my time of my presentation. So we're moving fast here in these video clips. But he had a mild oral phase impairment and he had a digest 4 profound pharyngeal phase impairment. Okay, he had velopharyngeal incompetence. He had internal lymphedema of the pharynx and larynx. You can see multiple repeat swallows, 8 or more, in efforts to clear the liquid bolus and inability to clear the puree bolus despite multiple swallows. So it was a struggle. That pudding just went right into his airway. And if you notice, that was a very delayed cough, but he was able to kick it out of his airway and then subsequently going to fall back in, right? So there was a lot to talk about. Okay. So you get the gist there with his really poor function and his flap, and also just complete defect here of no contraction. There's a lot taken. So digest 4. Okay. Um, Moving on. Ultimately, um, regarding intervention, this was a tough case. Education and counseling are key, right? He was brought back to the clinic to watch his video, learn about his current swallow mechanics, understand the impact of the resection and reconstruction on the pharyngeal phase, safety and efficiency, and my plan for optimizing him. His goal was to not have a feeding tube, and he wanted to eat everything he wanted when he wanted with ease, i.e., return to baseline. I was frank with him that I could not restore. I could not give him back what the surgeon took away. And given how severe his impairment was, I was likely not even going to make a dent in his dysfunction. And I would say that if we took a poll, most speech pathologists would say, stay NPO, you got your G, you're going to need your G indefinitely. And I'm not sure that I'm going to do anything with you because I'm not sure it's going to make a really big difference. The prognosis was therefore guarded, but I wanted to try and see if we could have him swallow some sort of liquid consistency more safely for pleasure. And if he was willing, we could see where it goes, but I couldn't guarantee anything, right? And that was how I spoke with him. So here was my plan. Given his chronic aspiration status, first and foremost, we discussed the pillars of pneumonia and how to mitigate risks for adverse health outcomes like pulmonary infection. In particular, diligent oral infection control to reduce the pathogen load of aspirated secretions and material, and reflux precautions given his G-tube feeds. We discussed spontaneous swallow frequency and how this reduces after cancer treatment. We produce 750 milliliters of saliva a day, so reminders to swallow his saliva more often, cleaner saliva because he's keeping his mouth clean. All right. And that definitely drops after head and neck cancer treatment, as well as in neurodegenerative conditions, how frequently you swallow. Then he needs intensive training to practice swallow form because it was a pretty discoordinated swallow with a big chunk missing. And we need to apply that to oral PO practice. We completed an advanced variant of McNeil and focused on 2 to 4 ounces of PO twice per day. So an AM and a PM exercise, applying a hard swallow, throat clear, re-swallow technique. and kind of moved him from water to a different thin liquid that's not water, like coffee and juice, and then thickened beverages for relative strengthening, and then puree. And then, of course, we discussed respiratory strength training via EMST 150 to optimize his pulmonary clearance given that chronic aspiration status. And then we discussed lymphedema treatment, um, which is, complete decongestive therapy. And it has four prongs. It has skincare, range of motion exercises, and it has drainage from manual or advanced pneumatic compression, and then post-drainage compression. And this aims to help the bolus move better through particularly the pharyngoesophageal segment region, and reduce airway invasion from overflow from the piriform sinus retention. If you saw the piriform sinus retention, there wasn't a lot of space there because it's so swollen, it was just falling into the airway after the swallow. So then those referrals were made for lymphedema intervention. And then finally, we discussed for future a prosthodontic referral for his BPI, palatal obturator or lifting device, and see if that can help kind of seal off that valve for potentially better pressures to strip the bolus through. So that was my plan for him. And following 3 months of intensive intervention of these things, believe it or not, this man improved. Let me show you. So you're going to see liquid on the left, pudding on the right. Remember, he couldn't get the pudding through. Boom. It's not perfect. It's very impaired still, but you saw liquids definitely improved too. So overall, he went from a profound to severe, digest 3 for both safety and efficiency. And you can see the impressive reduction in the number of swallows to clear, how the pudding is mobilized through the pharynx now. Um, He had improved control over his airway invasion. He had less spillover from the piriforms because of the lymphedema treatment. He had an overall improved coordination of swallow. Okay. So this was a win. I did not think that he would make improvement enough to move from a 4 to a 3, but he did. And, it was frustrating for him because this was I was impressed with his treat his recovery to this degree. And I told him that if he kept practicing, that he would continue to improve, but I don't think he would be able to get him to where he was before because of what was missing from his throat, right? So let's talk about where his update is now. So the patient was highly motivated by this. He felt really rewarded. He was eating puree and like kind of minced foods, and he was drinking liquids. There was no restriction on viscosity, and he needed to apply the technique of swallow, throat clear, re-swallow so that he can constantly kind of kick things out of his airway as they were attempting to enter, right? So these strategies just optimize safety and efficiency. So and there's his moving from a 4 to a 3. So at our subsequent follow-up encounter, I advised him that he would need to keep up all of this to continue maintaining his function. Okay, it's not just like he has to continue to eat in order to exercise the muscles and keep things moving. He really wanted his G tube out. And I told him I did not think that he was quite ready for that. And I never say really never anymore, but I did say that he would have to work really hard at this. Okay. So, but in order to have his G tube removed, at least with our NTAC clinic, which is enteral nutrition clinic, he has to maintain his weight through oral means only for an entire month, right? And not lose weight and not be using the G. So certainly this would be possible on a predominantly liquid-based diet, but he would have to try. So we partnered with a dietitian, and it was a real struggle for the patient. It took him 3 more months, but he got his G tube removed and essentially living on very high calorie boost. That was his choice. He really wanted it out, and he was okay with consuming that, and he was happy as a clam. But unfortunately, 1 year later, he reported that he had to have his G tube replaced because he ended up not keeping up on it, became more frail, lower BMI. And so when he spoke to me, he said, it was really hard accepting that this is my new normal, but it is what it is. So this was just an important case example to show you like it was a small little improvement on the digest grade, but it was big for his quality of life. And that, with evidence-based interventions, I still think we should apply and try and see what happens when you have a motivated patient, even when you know that the prognosis is going to be a tough one. Okay, let's jump into case two. So this is a 70-year-old male, and he was diagnosed with a large right base of tongue non-HPV related cancer, which often indicates a worse prognosis. Tumor board recommended upfront surgery with adjuvant chemoradiation, which he elected. He was then referred to the SLP care pathway. So the patient was seen for a preoperative counseling appointment by the SLP to establish baseline functions and provide education and counseling on what to expect again and the anticipated trends with speech, swallow, lymphatics, and mouth opening. And he completed a preoperative baseline swallow study, which showed normal swallow mechanics, digest zero. So the tumor was not currently impacting his swallow safety and efficiency of his pharyngeal phase. He then underwent that surgery. He had a transoral robotic resection of the right pharynx with bilateral neck dissections. A nasogastric tube was placed. He had an unremarkable hospitalization and a post-op surgical follow-up who noted reduced tongue range of motion, poor secretion management, so like real gurgly voice when he was talking, and resonance changes in his speech. His first fees post-op was post-op day 11. And at that time, his EAT 10 was a 40 out of 40, of course. He was a voice of one, he had an NG tube, and he was found to have a severe to profound impairment. So a digest 4, it was an E4 S3. So we gave him, well, and I should say at that time, he could not compensate for his safety and efficiency impairments, and he was not a candidate for nasogastric tube removal because that would place him at risk for adverse health effects and complications. So it was recommended that he return in 8 days to have more time to heal prior to reassessment. And he was instructed to start rigorous oral infection control practices, increase his swallow frequency, and begin rigorous daily exercises with water, 4 ounces in the morning, 4 ounces in the PM, and using the swallow technique deemed to result in the least amount of airway invasion per our fees. And we discussed that there was a possibility that the feeding tube in his nose may need to be transitioned to a G tube, particularly given his anticipated post-op radiation. So that second fees, which I kind of jumped the gun and played on, was at post-op day 19. His EAT 10 was still 40 out of 40. His voice was now a 2 from the daily water practice. He had mild improvements, but still suboptimal ability to compensate for the airway invasion that was pretty persistent and all the retention. You see a lot of internal swelling in there, right? So he was eager to actually transition to the G2 because he could not wait to have the nasogastric tube taken out from a comfort standpoint. It was driving him nuts. So we did, he was instructed to continue daily secretion and water practice with the technique and oral infection control programs for another 2 weeks until the pre-radiation swallow study, where his EAT 10 score was now a 30. So he's feeling better about swallow. I'm going to play the video here. His voice level remained the same. And the findings revealed a mild oral phase impairment and a moderate to severe pharyngeal phase impairment. That represented a mild improvement in safety. So level 4 IDSI puree was the starting food consistency, no restrictions on liquid viscosity. And here was the graph. I'm just waiting to play the rest of the video clips though. So he was working hard to clear this stuff through. So that was his first and second fees, and he's making little progress little by little with time and practice. Okay, so what did I do for intervention? I actually was blessed with 1 whole month of time before starting radiation for whatever reason. It wasn't delayed because of his swallow impairment. I'm not sure if it was an insurance issue, but we normally don't have that much time between surgery and radiation. We usually have about 6 weeks. Here I had a whole month to do something with him to get him going so he can go into radiation with better function. So the patient and his family were brought back into clinic for education and counseling, specifically to review his swallow study, discuss the progress that he had made since his surgery, and what we plan to do now to optimize him before radiation starts. So first and foremost, again, we talk about those pillars of aspiration, pneumonia. And he had already been really quite diligent with his oral infection control program, so that was great. Second, we wanted to initiate intensive swallow via McNeil, not an advanced variant, true McNeil like you learn when you take the class. And so I moved him
Sorry,
up
smile.
from a level 6 to a level 11 in 3 sessions. And his goal was steak and potato. He was a steak and potato man, and this is exactly what he's eating right now. This was his goal meal. He was just rocking it. He loves the flowered shirts. You'll be seeing that again in a second. He cracks me up. Okay, so then given the safety impairment, we initiated respiratory strength training via EMST 150. And we also wanted, there should be a little asterisk here, yep, to initiate lymphedema treatment, but that ultimately we had to defer it until after radiation was completed because we just couldn't get him into PM&R that quickly, or get him like a flexi-touch device that quickly. So that was a bummer, but we would address it. So that was on the docket. And then same thing with pre-radiation counseling. And what we're doing here is we're discussing the Eating All Through EAT radiation program and the pharyngo size program. Given that there's a loss of resistive bolus load during radiation, this program sets to augment that. So rehabilitation prior to radiation transitions into swallow preservation and just maintaining function during radiation. So my goal with him during radiation was for him to maintain a FOIS-3. He has a G tube, but consistent daily oral intake, and not just of liquids, of solids. He needs to swallow solids every single day. Okay, because that's going to be your largest resistant bolus load. That's going to be the strengthener. That's what's going to have the largest range of motion for all the swallow structures. And that's what keeps things alive and well during radiation. So remember that a lot of people who go through radiation end up having a regression in how much solids they take in. And a lot of them turn to an all liquid diet. So sometimes we go in with really good progress, we backtrack a little, and then when the toxicities chill out, we boost them forward again. So I worked with him back to a full oral diet after radiation ended. He was then seen for his 3-month post-radiation reassessment as part of the care pathway. He was still feeling like food was getting stuck in his throat, but had been eating regular foods and had not been using his feeding tube for at least 2 months at this point while maintaining stable weight. So let's look at where he's at. And this is sped up for time's sake. What a significant improvement this man had in his swallow safety and efficiency. Now considered a 1, mild, which was incredible. Okay. He would not be like this if not for speech pathology intervention. Okay. So his oral phase impairment also resolved. No restrictions on texture or viscosity was recommended using the MDTP swallow technique. I wanted him to swallow twice for solids, throat clear, re-swallow occasionally with liquids, especially if it was a larger volume. And I told him to minimize how often he takes a sip of liquid during a food meal to best work out the oral pharynx. So his feeding tube was removed, but I don't know if you can spot it. Real quick, there's the amazing progression. He's come so far. We would love if he got here, but sometimes we're not quite there yet. Lymphedema. This man developed a heck of a lot of lymphedema. Okay, so immediate intervention was recommended now at this point. He was cleared to do so at 3 months post. So he was to initiate lymphedema treatment every morning. He was to do some manual lymphatic drainage or use advanced pneumatic compression. And then I wanted to see him 1 year from that point, which would be 15 months post-radiation, for ongoing surveillance and to assess for treatment effects. So here's the 15-month post-radiation swallow study. And look at this incredible reduction in lymphatics. And you're probably like, whoa, he's even smaller or thinner than he was before. And remember that the tumor itself causes lymphedema as well. So this, he looked amazing. And he used the Flexi Touch every day for a whole year. And so you can see significant reductions externally and internally. He also reported a 3 millimeter gain in mouth opening despite being within normal limits mouth opening. He had reported experienced recovery of his appetite, his taste, his saliva over that last year. He had stable function, so no change in his digest grade. It was stable and the exact same thing. Still, um, uh, a mild impairment, digest grade 1, and the same E10 score, and he maintained a voice of 7. So it was pretty incredible. So how is the patient doing now?
Okay. Well, my name is Chris Harris. I'm a patient of Jessica's, and Jessica has been very, very valuable getting me through the whole process of before surgery, after surgery, getting my swallowing back to where it needed to be is before I went into radiation, and then after that it was kind of start all over again and do it again. Great exercises, very clear instructions on how to do everything, and constant good motivation and good, essentially good progress, and being advised of the good progress throughout the process was very helpful for me to stay motivated, and it was uncomfortable certainly at times, but I just knew that what to do about it and to keep going with it, and it worked out exactly the way Jessica had said. So
thanks, Chris. Okay, a couple questions for you. Okay, so after we had met about what to expect with surgery, and we talked about when we would hope to remove the nasogastric tube, and likelihood of a feeding tube in a G tube. How did you feel when you actually did need to transition to a feeding tube in your stomach?
Well, actually, apparently the nasal tube had stayed in too long, I guess, and it was in the way. It was uncomfortable. The stomach tube was actually much better. Very pleased. I had to learn how to use that one as well, but certainly it made it a whole lot easier to again keep progressing with learning to swallow again, and that part was great. So
yeah, and so getting it out of the way so that we could focus on intensive swallow rehab, McNeil, before starting radiation. How did you feel moving from puree to steak?
Oh, great, because puree was fine, but steak is great. So basically at that time I could go out and eat with people and do whatever I wanted. So
yeah.
That was it went by very quickly, it seemed like. So.
And then how was it maintaining eating solids every day during radiation? Because everybody deals with pain usually.
During radiation, in the beginning, it was much easier, but then as we progressed, and especially once it finished up, they had said that would be the worst part, and it was. However, I had lidocaine mouthwash, and that made all the difference in the world, because I was able to go ahead and continue with eating solids and drinking everything I needed to do, and still supplementing with the stomach tube.
Yeah.
So I was able to pump in all the boost I could handle.
Yeah. And then how did it feel getting that feeding tube out before 3 months?
That was like great. That was like returning to normal, and I was pretty much accustomed to the new normal by that time. And of course, after going through the difficult periods, that was like easy.
Yeah, right?
That was very easy.
And then talk to me about your perception of the lymphedema treatment, because you knew about lymphedema from the get-go. We really started treating it 3 months post.
Yeah, the lymphedema, I went through the manual training and did that for a while,
Mhm.
and I would have kept that up, but the FlexiTouch from Tactile was so easy to do it that way. You put on the garment. Uh, you only were required to do 32 minutes. Although I liked it so much, I would do it much more than that.
Yeah.
And it seemed like well, my last CT scan said there was almost no interior lymphedema.
I'm so proud of you. Yeah, you were very religious with it and it paid off. Boy, did it pay off, and you've maintained. So I'm really proud of you. And last but not least, if you had not had a speech pathologist working with you point by point, minute by minute through your experience, do you think you'd be where you are now?
No, no. I was kind of at the time we were scheduling appointments about once a week or so, and I was thinking, wow, this is a lot of appointments. But it really was helpful because I made progress actually with each week too, and that constant monitoring was very helpful in realizing that I was making good progress, and that motivated me even more. And Jessica, again, you've been a great coach, and I feel that made a huge difference.
Yeah, I'm so proud of you. Thank you so much, Chris, for your time. You're the best, and thanks for being a teaching tool.
Well, thank you.
Okay, bye.
Okay, case 3. All right, here we go. So, this is a 69-year-old male who had a history of previous cancers of the cheek and tongue, necessitating resection and flap reconstruction involving the radial forearm, neck dissection, and adjuvant radiation. So he presented to the ENT clinic with jaw pain, and he was found to have osteoradionecrosis, necessitating another surgery. Okay, so this on top of his chronic impairments already. So he was advised at that time that that would be a really high risk for complications post-op because wound healing from the previous radiation and flap compromise, and he had 2 rounds of radiation already and multiple surgeries. So he was referred to the SLP care pathway. And I just want to point out, like, look at the tongue atrophy from 2018 to now, right? So he came over to us. And here's the timeline. The patient was seen for pre-op counseling and education by the SLP on what to expect with this mandibulectomy for the ORN and flap reconstruction. And so he already had a moderate trismus. He had impaired speech intelligibility. He had lymphedema and some degree of fibrosis already. He reported doing a very short stint of self-manual lymphatic drainage for about 6 months in 2018, but he did not continue it. He then had a pre-op swallow study. I'm sorry, he did not have a pre-op swallow study. The last swallow study we had record of was in 2018, where he had a moderate efficiency impairment, no safety impairment. So that was overall considered a grade 1, according to Digest. His E10 score was a 25, and his voice was a 5 on, he was on like an ITSE level 5 diet. So we had a frank discussion about the fact that he may require, very likely require, a G-tube after surgery during the rehab process. But he stated that he hoped that was not the case, of course. And then he underwent his surgery. He had a segmental mandibulectomy with an osteocutaneous free flap reconstruction with a trach and a nasogastric tube. This was a 2.5-week admission. He had a Passy-Muir valve issued for his trach tube as an inpatient. He then followed up with the surgeon and was decannulated 2 weeks after discharge. The surgeon kept the NG tube in for a longer period of time than I would have liked, in hopes that patient would recuperate enough from a function standpoint without having to transition to a G. But alas, we finally saw him, and the NG tube is in there, for a swallow study at 6 weeks after his surgery. And this is what his flap looked like. Okay, kind of healed up. And here we go. So his mouth opening was unchanged from pre-op baseline. So his trismus didn't get worse. His E10 score was increased to a 38. His voice was a 1 now. I kind of fast sped this up from a time standpoint, but you can see he really has to jerk his head back for posterior transit of the bolus, and he's just kind of trying to get the lay of the land with what's going on with his new swallow and all of the acute on chronic lymphedema that was going on externally and internally. So his oral phase was considered profound. His digest grade significantly worsened from 2018, obviously, of what we knew, to severe. And so his sensation of instances of airway invasion was suboptimal. He was not aware of how much liquid was entering his airway on a regular basis, and therefore he was not expelling it spontaneously. So it was necessary that he use a consistent throat clear re-swallow strategy with every sip in best efforts to expel and reduce the degree of airway invasion, which was shown to be an effective strategy under fluoro. Repeat swallows were needed to optimize the efficiency or clearance given the intense pressure differential from the edema. So no safe food texture could be recommended, liquids only, and specifically water to start off with, right? With the technique, but only after the patient showed diligent oral infection control practices, which he was not, doing really well at. So we had a really long talking to about mouth care, and he needed that NG tube to G tube conversion until he could better compensate. And that could take several months. I was very honest with him that I don't know how long this is going to take, but we can't keep the NG tube in for that period of time. And our focus was first going to be on liquid for pleasure. So here he is before, at least in 2018. Here he is now, severe. And so what did I do for intervention? And as with the previous cases I showed you, the patient and spouse were brought back to the clinic for extensive education and counseling to include watching the video, learning, understanding his current function, what was my plan of care, what it entailed. This patient had a big dent in his functional abilities after the surgery, and I was honest that I may not be able to get him back to baseline given the degree of resection and reconstruction, the acute on chronic lymphedema and fibrosis, but I would try my best to get him as close as I could. So we talked, of course, about the pillars of pneumonia. We needed to focus on swallow form to improve coordination before strengthening the system. So we completed an advanced variant form of McNeil. And kind of like the previous patient, there was daily exercise twice a day for a minimum of 10 minutes of practice, AM and PM, with strict use of the swallow technique. For him, it was swallow, throat clear, swallow. And I used a metronome kind of thing because he needed to be quick with this. So if you think of a metronome, like swallow, throat clear, swallow, throat clear. He even downloaded the metronome app on his phone, which is free, so that he can really get a rhythm. And it's great for like getting the swallow started faster. It's just kind of a visual and auditory cue. And so, no talking during swallow practice. And over time, the oral consumption times became shorter because we had progressed from water to a non-water thin liquid, and then thicker viscosities as a relative strengthener, and then a slippery puree, and then a denser puree. He wasn't allowed to flush until the very end of eating that puree. And so that's how we moved along. And then, of course, we did EMS T150 for the chronic aspiration status. We then initiated lymphedema treatment, and there he is wearing the FlexiTouch suit. He loved it. Future intervention would focus on trismus intervention once he was cleared by surgery, because remember, he had a acute on chronic trismus. And a prosthodontic referral for a hard palatal lowering device, bringing the hard palate lower so that his tongue could try and make better contact for improved posterior bolus transit, or a possible lift for his VPI. But we really couldn't get him to a prosthodontic until his mouth opening improved. So those were future goals. And so following 3 months of intensive swallow intervention, the patient presented with improved oropharyngeal function overall. His profound oral phase impairment mildly improved, and his pharyngeal phase safety improved to the next category, which is now moderate. And while he did have less pharyngeal retention across consistencies, it did not qualify to move him to the next category according to digest. So a puree diet was recommended, and no restriction on liquid viscosity using the McNeil swallow technique. And then he went from a Foyce 1 to a 4 with his feeding tube removed, which was amazing. Okay, so here's his chart. And he was to return in 1 year for reassessment following the SLP care pathway and see if he made any further improvements. So how is he now?
My name is Larry Zacks. I'm 70 years old, and I'm a patient at Mayo Clinic in Arizona. I've been asked to describe my impairment post-surgery to both my swallowing and speech, and how those impairments were improved through speech and language therapy. After surgery, I received therapy from the speech and language pathology department in order to improve my swallowing, my speech, pulmonary clearance, lymphatics, to improve my mouth opening. My goals were really very simple. One was to get the NG tube removed and replaced with a G tube, and then subsequently to be able to take nutrition orally so I could have the G tube removed. Also, to improve my speech so that I could return to work. We started with ice chips and then progressed to water, and I was introduced to the three-step process, which entails sipping, swallowing, and clearing. Then certain techniques were introduced as well, like using a metronome and repeating the process during swallowing so that it became habit. Then after progressing from clear water to juices and on to thickened liquids, then to puddings, and then to pureed foods. It's still a work in progress.
And I'm going to just skip the last video because it's kind of long and we're running out of time for the last case. But this final video that I would play talks about how important lymphedema treatment was for him and how much he enjoyed and still enjoys using FlexiTouch. So now we're going to move on to case 4, the last one. So this is a 62-year-old male, and he had a remarkable history of base of tongue cancer and definitive chemoradiation 10 years prior to when we initially saw him, treated at an outside hospital. He was referred to Mayo Clinic to see Dr. Lott and myself for a swallow workup. He was referred from his primary care because his pulmonologist was concerned about this worsening pulmonary fibrosis and need for supplemental oxygen. I mean, he would get short of breath just even walking outside. So his presenting complaint was persistent unintentional weight loss. He lost 10 pounds over the last year, and these recurrent lung infections that were necessitating hospitalization. So we completed a baseline X-ray swallow study, and I have it sped up here, okay, for time's sake. His EAT-10 score was a 36, and he was a FOIS-4 because he was on an only liquid diet. And he presented with chronic and significant pharyngeal phase impairment secondary to the nature of his late effects of radiation, which are insidiously progressive. And so you see consistent, persisting airway invasion of liquids, thin and thick, with really no reflexive cough, and it was only mitigated but not eliminated with strategies. We tried supraglottic, but no one's going to do that every single swallow for the rest of their life. They'll pass out. And certainly it still wouldn't stop aspiration from happening, right? So consecutive chugging was also helpful, but still can't stop aspiration from happening. And so there was also high risk of airway invasion and blockage of airway, of food retention, both with consecutive bites and following a liquid flush. So again, without a sensory response. Here was his chart. So no safe food texture could be recommended, but there was less risk of breakaway pieces that could be aspirated or the overall volume of aspiration of retention with pureed texture using the recommended technique, right? No safe liquid viscosity could be recommended, but we could reduce the degree and frequency of aspiration of thin and thick liquids with the strategies I gave him. So there was just no solution to having him not aspirate. When I brought him back for a review, a comprehensive review, I reiterated that he has significant safety and efficiency issues, and those are the reasons for his unintentional weight loss and being on an all-liquid diet, this heavy diet modification, his recurrent lung infections, and his poor healthcare-related quality of life. And so we discussed the difference between compensation and rehabilitation. And at this point, the severity and the chronicity of the impairment and underlying etiology of radiation fibrosis precluded him from any rehab that could make a functional difference for him in his safety and efficiency. And regarding compensation, we discussed strategies and considerations to optimize the safety and efficiency with the understanding that none of these can preclude aspiration. So We discussed pulmonary clearance training, and he already owned an EMST 150. We talked about a supplemental enteric route, like a G tube, but he would still be at considerable risk for pneumonia. And it was not in line with his wishes at his time. He didn't want a feeding tube. He said his goal was just to stop aspirating and to not develop any more pneumonias. And I explained the only way that that's possible is a functional total laryngectomy, which he was, okay, appreciative of the information, but really not open to that at this time. So let's move on. What happened? Within 2 months after that study, 2 months, he underwent a G-tube placement, which helped him improve his nutritional status and stabilize his weight. He consumed less by mouth for burden relief. Okay, so he was doing Kate Farms through the G-tube, and he had only one latte and one glass of wine by mouth each day, my kind of guy. And he still developed another pulmonary infection that required hospitalization. And that was his final straw. He was like, that's it. I can't take it anymore. His pulmonologist was gravely concerned. So he did return to us 4 months later for reassessment and to explore other options. So he reported that his swallow actually was worse. And indeed it was. He went from a digest 3 to a digest 4, which is profound pharyngeal phase impairment. And the reason for this deterioration in such a short period of time is because of his reduced use of his oral route. Use it or lose it, right? He got the G-tube, he stopped eating as much. And so that really expedites, that disuse atrophy expedites the fibrosis. And so he wanted to discuss that functional laryngectomy further. We completed pre-laryngectomy counseling, and we covered realistic expectations. What would it be like breathing, speaking, and swallowing after the surgery? He demonstrated the necessary visual acuity, manual dexterity, and cognitive intactness necessary for managing a tracheoesophageal puncture. He also had great family support and assistance. And so I set him up for a peer-to-peer visit, which is where we match the patient's situation with the former laryngectomy patient of the same situation, so that they can speak and visit with each other and kind of get those questions answered that a peer could provide it rather than a medical professional. And so he underwent that surgery. He had a cricopharyngeal myotomy and a primary TEP, and he had an unremarkable hospital admission and negative leak study with Omnipaque. And then he also lost 7 millimeters of mouth opening. So he met the criteria for trismus at 35 millimeters. We wanted to work on jaw. So once the patient was fully acclimated to a regular diet, a few weeks later, we completed a post-op swallow study, which essentially serves as a new baseline for this laryngectomy patient because swallow and voice now share the same pathway, and structure and function can both change over time, negatively impacting the swallow and voice or voice. So he presented with a highly functional oropharyngoesophageal mechanism as the sole route of nutrition, hydration, and medication. His G-tube was removed, right? And he demonstrated stable weight, not using it for 1 whole month. And all of his physiologic aspects of his pharyngeal phase were functional, lending to impressive bolus passage through the neopharynx, but he did have, as you can see, significant external and internal lymphedema. This was acute on chronic, particularly at the pharyngoesophageal segment. That cricopharyngeus is huge. And so no restrictions on texture or viscosity were recommended. He could handle anything he wanted, but he was uncomfortable. He had a lot of congestion and tightness inside of his throat, and obviously we see it, right? So he returned for another post-op SLP visit. We reviewed his video. We discussed his plan of care. So these were the interventions. We did lymphedema treatment, start right away. And it would also likely result in less perceived effort by the patient with swallowing and voicing. And also talked about how to keep that voice prosthesis alive and well and living longer before failing. And I also recommended that he have a swallow study every year to keep tabs on that structure and function, as I mentioned, right? And fluoro is an excellent way to do that. And so where is he now? By the way, he's holding his hand over like this because he felt that during the recording he projected better.
So what were my initial thoughts when a total laryngectomy was proposed? Well, I knew my condition was deteriorating, but, I certainly did not believe that it warranted the removal of organs. At least that was not my mindset. I thought there was something else. So to answer the question, I was shocked. And therein lies the challenge for both the doctors and the speech language pathologist. but primarily the speech language pathologists, because they're the ones that bring you along and make you understand that this is necessary. What were the factors that made me decide to proceed? For me, it was a cascade of events. There was a few emergency room visits for pneumonias. There was a very serious swallow study result that was deemed life-threatening, not good. And finally, there was the specter of permanent lung damage. And I think I dodged that bullet. And that was the thing that really pushed me over the edge to proceed, was when I heard those words, I knew I had to do something. Did the surgery go as I expected? Well, the short answer is yes. You don't feel that way at the time, but, because your recovery is, onerous, right? You've got 8 tubes coming out of your body. But I recovered very quickly. There was astonishingly little pain after the surgery, which is, to me, just gobsmacking. I was walking within 3 days. I left the hospital after a week, and I was speaking after 2 weeks, which is equally astonishing. So I would say, yeah, the surgery went as I expected. What was surprising to me about the role of the speech language pathologist? Well, the most surprising thing was how much it is its own specialty. They are really, the SLPs are really the ones that guide you to this surgery, and they're the ones that you go to afterwards for essential maintenance, changing TEPs, all of the maintenance issues, voicing. That all is the SLP. It's not the surgeons. And an SLP is not an ENT, and an ENT is not an SLP. These are very distinct things, which I learned. I had profound lymphedema right after the surgery, as I suspect most patients do. I don't know that, but I suspect it's true. It reduced quite quickly, but in my case, I had radiation treatment, a decade prior, and that did create, I think that's the reason that I had lasting lymphedema-like symptoms. And I got massaged twice a week for 2 years to try to treat it. And I think that was very much worthwhile. I'd recommend it to any patient coming out of this. Lymphedema is the biggest hurdle in this surgery. It's the recovery from the surgery is quite transient. It passes, but the lymphedema stays with you, and I think it's the largest patient challenge. So quality of life after the surgery. Well, in my case, I think I did really well. Within 3 months, I was sailing. The following winter, I was skiing. I'm able to interact with people. I speak softly, so I don't do well in large crowds. But, no more feeding tube, no more supplemental oxygen, really back to living, which is great. I've been doing peer-to-peer meetings with patients at Mayo, contemplating the surgery and helping them to understand that, there is a voice afterwards, and life goes on. So, quality of life is certainly much better than it was.
Oh, great. So those are my 4 cases, and this is just like a recap of some difficult conversations, right? The NG tube to G tube conversion after surgery, swallow function prognosis after treatment, and also life-altering surgery like a TL for enhanced healthcare-related quality of life. Those are just some of the things we talked about tonight, but hopefully you learned some interesting things or picked up a couple things that you wanted to look into. These are my references, and I look forward to answering questions. I know I went right up to the mark, but I will stay on and answer as many questions as you want because I'm sorry I took that time.
Well, Jessica, thank you so much. The chat is already filled with a lot of positive feedback. A quick recap on ASHA CU stuff, and then we'll jump into Q&A. I did put this in the chat, but if you weren't able to read it, we are offering this for 0.1 ASHA CUs or 1 PDH. Just fill out the brief survey, which is in the chat. It'll also be sent out via email. And if you'd like a certificate of completion, email us at tims-unum@tims.com. And this again will all be emailed out and the replay will be up on our website within 48 hours. All right, so let's dive into Q&A. Jessica, I will start with one that has come up frequently, which is about the time frame of lymphedema. So several people ask specifically when is the cutoff, basically, like when is lymphedema treatment not effective in your opinion?
We don't know yet. Because in my study that I published, I saw internal reductions of internal structures at 26 years post radiation. That was my guy that was the most out. It doesn't mean, and just what my feelings are, I don't think it made a dent in his swallow safety or efficiency, or that it would with continued use, but he certainly felt better. He felt less congested and he had other quality of life aspects that were improved. And so that's a win. But certainly the most effective that I've seen is when it's 3 months post and really bringing that down and actually impacting swallow safety, and even improving efficiency as well. And so I'm actually working on publishing a case series of exactly that. So I can show you that in lymphedema treatment improves digest scores.
Awesome. There were also a lot of questions specifically about the Flexi Touch regarding how are you getting access to it, and specifically how are you getting access to it so early?
Yeah, I mean, just we diagnose and if not for the lymphedema treatment, I mean, that's how we see these improvements in swallow function, right? And also mouth opening and range of motion and all these things. So we partner with PM&R, we send referrals for them, and then also we get them plugged into Tactile Medical, the company. The company then reaches out, does a free home trial, helps them get all of their documents and medical documents in order for the insurance company, and takes care of the verification process. Now Medicare is covering, but they do need a couple of sessions with PM&R to do that. So they should be going to PM&R anyway. So it's perfect.
Awesome. This is Cindy asked, what do you recommend as maintenance after consistent therapy, such as between the yearly videothoracoscopy in terms of lymphatic management, EMST, etc.?
So a lot of the things that we're instructing the patient to do, these guys are usually working with a full tank and they know what's going on and they're very motivated. So you're setting them up and you're educating on what to do for swallow safety and efficiency, the strategies or whatever they need to do, the technique in order to keep eating and exercising their muscles and not stop eating, right? And doing it in the safest way possible and the most efficient way possible. And once they've got that, then you can if they are cardiac aspirators or if safety is a concern, you're showing them how to do EMST 150, and that's something they do independently. If they have trismus, you show them how to do the aura stretch, and that's something they do independently, following like if it's radiation, the 5530 protocol, if it's just surgery, 777. And then lymphedema treatment is a chronic condition. They will have it for the rest of their life, especially if they had radiation. So this is something they do every day. So you're educating on like the importance. It's on them. It's not you. You're telling them this is what they need to do. And I'll tell you, the patients who listen to exactly what I tell them to do have great outcomes. That's it.
Definitely. Here is another question. Stellar presentation, Jessica. Love the information on pneumonia prevention and pulmonary clearance optimization. In your clinical practice, what factors do you feel have the greatest impact on adverse pulmonary outcomes in the head and neck cancer population? For example, for the last case, was it the disease severity?
What were the question though was what had the biggest impact on what?
On what has the greatest impact on adverse pulmonary outcomes in the head and neck cancer population?
Oh, it's a loaded question. There's so many. He knows, Aaron knows that, but like yeah, sure, swallow severity and how well it's all the things he talks about in Bolus framework, and also the throat clear, the power of the throat clear. It's not just about keeping the mouth clean. It's not just what they're aspirating, the volume or the material, right? It's their clearance of it. So yeah, you can teach them EMST 150 and have them improve their throat clear power, but having them throat clear, proactively is to clear out what you cannot stop from entering their airway. So you can certainly kick it out. And it doesn't have to be this like crazy maneuver that they're not going to do or not do consistently because it's just not functional. It's just a throat clear. keep their lips closed, re-swallow. It's great, very helpful. Use it with almost everybody.
We have had a lot of questions about RMST specifically. Several people wrote in and asked if you have a preference between EMST and the breather. Do you have any thoughts on that?
Just my understanding is that the EMST 150 is the only resistive loaded one so I feel like that's the one I use. I know that my voice specialist counterparts use the breather for different purposes.
Definitely. We'll do two more just in respect of everyone's time. This person asked, and I believe that you mentioned this, but I think it's an important topic. That's why I'm asking you. But this person asked, how quickly does lymphedema begin after radiation?
Oh, well, you get lymphedema from your cancer, and then you get lymphedema from surgery. And then so going into radiation, they usually have some degree of fibrosis, actually, according to the genes literature, the genes et al. And I think it's her 2022 and 2023 paper. I've studied it too much. And the 2020 paper. But then also, if they don't have surgery, they're going to get it from radiation. And so it's going to start developing during radiation. It's going to heighten right after radiation. Some of it might come down a little bit, especially externally, but sometimes it can really appear right after the submental lymphedema, but all the while they'll have internal. And really 97% of patients will have internal lymphedema at 3 months post-radiation.
All right. So there are so many good questions, but I really want to ask you this one because we just talked about this the other day,
Yeah.
Jess. So this person said, do you have to wait until the patient is deemed cancer-free before lymphedema treatment? And then someone else wrote in asking about whether or not lymphedema treatment spreads cancer.
No, you don't have to wait until the patient's disease-free. Some doctors feel very strongly about that and just not being well educated or understanding what quality of life is and treatment of problems after cancer. But no, the lymphedema treatment does not spread your cancer. It's just important to treat the patient so that they can have improved quality of life and function. So, I mean, there was a guy who had active cancer who couldn't even fit his tongue into his mouth. It was just sticking out the whole time. He couldn't close his lips around his tongue. And he had so much lymphedema in his face that he couldn't even open his eye. And so working on that is important. And he was able to then put his tongue back in that. And, you know, I guess I'd frame it this way. While there's not a shred of evidence that lymphedema treatment spreads cancer, even if it did, I know many patients who would sit there and go, I would choose some intervention to help me with my quality of life right now, palliative care options versus like that risk. But there is not one shred of evidence that suggests it does. It has been studied in the breast cancer literature, and it also has been looked at in the head and neck cancer literature. There's a good study out of Germany. And it's also something that we're looking into at Mayo just to put it to bed. Oh, wouldn't that be great if we could move on from this silly myth? Actually, there's probably greater spread of cancer shred cells from cutting in and doing surgical resection than there is from lymphedema treatment. So hopefully
Yeah.
that will help set your mind, ease your mind.
So mic drop on that.
Thank you.
Amazing. Yeah, an amazing presentation. We did not obviously get to all the questions because there were so many awesome questions. And I just want to thank everyone for joining this evening. Jessica is on Instagram. So if you're on Instagram, make sure you check out her page. She posts all kinds of incredible information there. Check out her courses through Esophageal Collab. And she also has several through Tim's U if you want to go back and check those out. And with that, we will close out for the evening. Thank you all so much for joining us. Bye, everybody.
Thanks, Brooke. Bye, everyone.
Bye.